All right, so our topic for this month is safety plans, habilitation, and behavior supports with rights restrictions. So these are things that are amongst those safeguards that we expect to be in place when restrictions are used, especially when restrictions are addressing certain types of risks. And so, and it's one that we do um, it is amongst the most common of the safeguards that we see issues with in our compliance reviews. And these things are so important for a host of reasons, which I will get into here in a little bit. But we did a survey of kind of where to go with these trainings next and what topics folks most wanted to hear about. And this was the one that we heard from the most people they wanted to hear more about. So hopefully this will be helpful. And I also want to make note that a good amount of what we're talking about it today, we're going to talk about all of these things in relation to rights restrictions, but at least some of what we talk about today is not specific to just when these things are in place due to there being rights restrictions in place. A lot of what we're going to go over today is the division's expectations and helpful hints and considerations and things like that for anytime you're looking at a safety plan or asking a provider for a safety plan or behavior supports, facilitation, those types of things. So on the agenda, we have what is required. So what are the required supports with use of restrictions? And then why are these important? Because I feel like sometimes, and I don't think anybody necessarily consciously feels this way. I mean, we're all doing our best and we're here to do our best work for the folks that we support. But I think sometimes there's so many red hints and there's so many SOPs and there's just so much stuff that sometimes we start to view some aspects of that as like red tape, just boxes to check. We have to have a program. It doesn't matter if it's a good program. We have to have a safety plan. So if we have something that says safety plan at the top, that's good. These things all play a really vital role in those safeguards that we have to have in place whenever we're going to put an intervention in place that limits somebody's fundamental human rights. And so it's really important that we are doing our due diligence in relation to all of these things. And so I want to talk a little bit about why that's important, because sometimes these things are important in ways that we haven't thought about. And understanding that why helps us do our work better. And it also helps when we're having those conversations with guardians, with providers who may not understand that why, who may not understand all of the nuances of our policies and expectations. It helps us help them understand those things better too. And then we'll go into a few considerations and best practices, suggestions for when you're thinking about safety plans, facilitation, and behavior supports. So first we're going to talk about, like I said, what is required when restrictions are implemented. So the first one off the top, and this goes for every single situation in which a restriction is implemented for a participant. Sorry, I'm going to step back for a minute. Before I jump into safety plans and before we talk about requirements for restrictions, I do want to note, because this is something that we hear a lot of confusion around, and I think you all probably do as well. We are going to talk about, because this is a rights training series, these things in terms of what is required when there is a restriction. Please do not walk away from this training thinking that the only time you need any of these things is when there is a restriction. And that may sound silly, but that is something that I hear from providers. That's something I hear in conversations is there's no restrictions, we don't need a safety plan. There's no restrictions, we don't need a BSP. And that is a misunderstanding of our policies. And reframing that, the thing that causes us to need a safety plan is the same thing that causes us to need rights restrictions in some cases. So they both stem from the same thing, but restrictions aren't the thing that causes us to need a safety plan. When there are safety risks that provider staff need that risk and exactly what we want them to do when that risk comes up, communicated to them, there needs to be a safety plan, whether there's restrictions or not. So those safety risks are what cause us to need restrictions in some cases, and also what causes us to need a safety plan. So when a provider says, why do we have to have a safety plan? Please don't say, well, because there's restrictions. That is, we do require those things to come together. But the reason is that if there's a safety risk that is so significant that it requires the limitation of a person's human rights to mitigate, then they need to have a safety plan because of that safety risk, not because of the restriction. So want to put that out there because I think that is a common point of misunderstanding. Because I think when a few years ago, we put a lot of emphasis on you have to have these things when there are rights restrictions, and people took from that, this is the only time you need these safety plans, behavior supports, etc. So want to put that out there before we go any further. So safety plans. So when a rights restriction is implemented, there must be a safety plan. Like I just said, that's not the only time, but when there's a rights restriction, any kind of rights restriction, psych meds, any kind of rights restriction, there must be a safety plan. That safety plan must contain a description of all identified safety risks for the participant. And that means, you know, all of the safety risks, not just those that are being mitigated with a rights restriction. And then if there are identified behavior risks, the safety plan must contain a list of known triggers and warning signs. You might hear them called like precursors and antecedents. There's some different words we use around that, but that's what we mean. We need to educate staff on what things indicate that unsafe behavior might be coming, or things that they might do, things that others in the environment might do, aspects of the environment itself that might be more likely to precipitate an unsafe behavior so that they can modify that environment. They can modify how they interact with the participant, etc. And then the other piece of it is that I highlight on the slide is detailed instructions for DSPs to follow for when those safety risks occur, including any supports, protocols, strategies, equipment that are needed to mitigate that risk. And that is the piece that then, if there are rights restrictions in place to mitigate those risks, those instructions for how to mitigate the risks will include descriptions of those rights restrictions and how to implement them and when to implement them in relation to those, to the identified risks. So this list isn't comprehensive, but these were the elements that I really wanted to highlight. And the other thing, and I have a few things linked throughout this presentation, you can get to these links are active in the slides that I have attached to the meeting invite. Our clinical team has developed some wonderful checklists that lay out what a safety plan that is compliant with division policies and expectations looks like and the elements that it has. And so when we are talking with a provider about a safety plan and we feel that it doesn't have all of these essential elements, we should be going back to them and saying, we need more. This safety plan is incomplete. And this checklist is publicly available. It is on our public website. It can be shared with providers. It is actually out there on our website on the provider page. It is intended for providers for them to use as a helpful guideline in writing safety plans. So if you have a provider who isn't writing safety plans that contain all of the needed elements, this is something that you can utilize with them as a tool to say, this is what I need the safety plan to have, and it doesn't have this and this, so I need you to work with me to get that updated. So any questions about safety plans and kind of those essential elements?
Most providers have this information though, right? For people that are here with us, new employees, is that safe to say?
They should, because what is in that checklist is also in our policy manual and probably a number of other places. However, you know, we know that providers, we have a lot of tools and resources and things on our website, but, you know, we can lead horses to water, but we can't make them drink. And so we know that there are providers out there who aren't utilizing this, or maybe even if their leadership are familiar with these things, maybe the people at the level who are actually writing the safety plans don't know that these things are out there. And so that's why I wanted to share them today, because folks are always like, you know, what can we share with providers, or what policy can we point them to if they're giving us trouble about some aspect of what we're asking them to do? And so these checklists are a wonderful tool that kind of lay it out very clearly what a safety plan is and what it needs to have.
Yes, I just want to say thank you. Thank you for saying that, because we do struggle with them, but I think for new people, you know, that's important to know that some of the providers do an excellent job, but some don't always use the tools that are given. And it's not intentional. They're just sometimes as pressured with deadlines and as we can be, and things get missed. It's just sometimes human error, but things get missed even after long ISP meetings and notes being taken. I just, like you said, though, a lot of times it's the person writing it isn't always at those meetings. They're given the notes and discussion later with the person that was. And yeah, so it's, thank you. It was well said.
Yeah. And that's why, even though the provider has the responsibility for the safety plan, it's a collaborative effort, because ultimately it becomes a part of the service plan. It's a component of the service plan, and we review it with the service plan. So the provider is responsible for developing it, but when you receive it, you have responsibility when your provider or when your supervisor reviews your ISPs and its components. You know, we all have responsibility to make sure that all of those documents that are part of the service plan meet expectations, and it really is a collaborative effort.
Thank you, Sarah, for speaking to that. I can't emphasize that enough, that when you attach it, you as an SC have agreed that it meets our requirements. I also just want to add that, and you maybe spoke to it, Sarah, but those are optional templates. We can't force providers to use them, but they're a really great guide and tool if they're just not sure where to start. And that checklist, everything that is required is within it, but the templates themselves, we can't ask them to specifically and only use those templates.
Mm-hmm. Yeah, so we have a checklist, but what Stacy mentioned, the section of our website that those are on, there's some other tools that our clinical team has put out there, including templates that providers can choose to use when they develop safety plans, BSPs, etc. So here, if you go to our DD waiver providers page, all of that is here under this list. So the checklists I'm highlighting today are here, but also some presentations that the clinical team has given, templates that they've developed that providers can choose to use. There's a YouTube video about it, about these things. So these are all great resources that you can make providers aware of if they're struggling to understand why you're asking for what you're asking for, or what exactly you're asking for. And Cindy, I was just going to say that next before we moved on to this slide. When I talk about a safety plan, it doesn't need to be titled a safety plan, and it doesn't necessarily need to be just one document. Some providers choose to have a seizure protocol and a fall protocol and a choking protocol for a person who has all three of those risks, or they choose to call it staff supports or a safety protocol or different things like that, as long as it serves the function of a safety plan and it has the required components in that checklist, it doesn't matter what they choose to title it as an organization. And so that's something to be mindful of as well, because you will see things out there with different titles, and you might see the needed components for each risk a person has across a few different documents. That is acceptable as long as all of the risks are covered and all of those things have the required components, even if they're separate, even if they have different names, that kind of thing. Yeah, we really want to be flexible with our providers, because at the end of the day, it doesn't matter what it's called as long as it does what we need it to do to support our participants and others to be safe. So the next thing we're going to talk about are behavior supports. So we're talking about formal behavior supports here. So when a rights restriction is implemented to mitigate a risk related to maladaptive behavior, and when I say maladaptive behavior, I mean problem behavior, target behavior, whatever term is, we want to use for that, that's what I'm talking about. When we have a restriction that is implemented to mitigate a risk related to maladaptive behavior, there must be formal behavior supports. And formal behavior supports start with a functional behavioral assessment. Any behavior supports that are not based on a functional behavioral assessment that meets the expectations we're about to talk about do not meet our requirement for formal behavior supports when a restriction mitigating behavioral risk is in place. So when we do a functional behavioral assessment, there's a few things, and I have to tell you, I see a lot of FBAs that really don't cover these things, and it's hard because you're not behavioral professionals, most of you. I'm not, and my team aren't. Most of your supervisors aren't, your SDs aren't, you know. And so we have, you know, we get these things developed by professionals, and sometimes we may struggle to feel like we can push back because we don't have the same qualifications and experience, education, and certifications that they have. But our role is to make sure that what they deliver us, it's not questioning their professional judgment or expertise to say this doesn't have the components that we have to have, and it doesn't meet what we expect for the assessment you've been paid to complete. So the first thing is that an FBA must be completed by a qualified professional. So a BCBA, an LIMHP, acronyms, a board certified behavioral analyst or BCBA, a licensed independent mental health practitioner or LIMHP, an advanced practice registered nurse or APRN, or a clinical psychologist. And a note that I want to make with the qualifications is that most school psychologists with our younger participants, sometimes teams will want to use like an MDT or something that is completed by a school psychologist as part of the participant's IEP as an FBA. Most school psychologists are not licensed clinical psychologists. And so they do not meet our qualifications. And so that is something to be mindful of. So in addition to being completed by a qualified professional, the FBA also must have a set of required components. And the ones I want to highlight are descriptions of the problem behaviors. So this one can be really important because sometimes behaviors get mischaracterized. And everybody has different perceptions of, you know, physical aggression and property destruction. They can mean a lot of things, but generally, like, they bring the same sorts of things to mind for most of us. But there are other things where that, inappropriate sexual behavior is one, but that can mean a lot of different things. And that is one that we see very commonly being normal, not inappropriate behavior being characterized as inappropriate sexual behavior. This is an extreme, but there was a participant that we came across that it said throughout her plans and things that she had a history of inappropriate sexual behavior, but when we got digging into some of that, one of the descriptions of that behavior was that she doesn't wear a bra under her clothes when she's at home, which is, I don't have to tell anybody who is a female or knows a female, not inappropriate sexual behavior, right? So, sometimes people, an innocuous behavior gets tagged with a label, and then we carry that label forward. And so then in every FBA after that, it says they have inappropriate sexual behavior, but we don't define it. And so nobody realizes years down the road that this isn't actually really a thing, and it maybe never was. So something to be mindful of. So when we're talking about an FBA, they should be giving descriptions of the problem behaviors. Physical aggression, is that hitting, kicking, pinching? Like, what does that look like for this person? Verbal aggression is another one where we see a lot of variance, because sometimes verbal aggression will be characterized as something like talking back. And it's like, that's not verbal aggression. If it is, I need a BSP, right? Another one, swearing, also would need a BSP. For that one. There's a difference between just swearing in general and swearing at a person or threatening them. And so making sure that FBAs describe the problem behaviors so that staff know what they're looking for. They know what they're supposed to document. They know how to respond, and they know what not to document as incidents of those problem behaviors. We don't want people using their own discretion to decide what verbal aggression looks like, because consistency with behavior supports is so important. The next piece of the FBA is the functions of the problem behaviors. So this is such an important piece, and we still see FBAs sometimes that come across without these or with functions that aren't really functions. So I'm going to click on the checklist. So this is the checklist our clinical team has developed, and it goes into more depth than what I have on the slide there. And there's a few things, odds and ends that I don't have on the slide. But an FBA must determine a function of every single problem behavior defined in that FBA that the participant currently displays. There are 4 functions of behavior. So if a clinician that you have completing an FBA lists a function of behavior that is not one of these 4 things, that is not consistent with our expectations. And the functions of behavior are escape, attention, tangible items, and sensory. So the functions of human behavior can be boiled down to one of those things. I got up this morning and got dressed and drove to work because I like tangible items, specifically money that I make by coming here. So if you're not seeing functions of behaviors, and the function of each individual behavior should be defined. There was an FBA I was looking at last week that said the functions of their behaviors are this, 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 and this. And I'm like, but which one is which? And like, because different behaviors are often have different functions. I might yell and swear for attention, but if I punch my staff in the face, it's because I want to escape a situation that I don't want to be in. So lumping that all together is really unhelpful then when we're trying to design a behavior support plan that will have functionally matched replacement behaviors, which we'll get into in a minute, to reduce the incidence of those things over time. It's really important. And then switching back to my slides, the last piece that I have highlighted here that I'm going to talk about is, so we have the problem behaviors defined. We have what their function is for each behavior. And then we have functionally matched replacement behaviors. And this is something that we see missing very often, because a lot of replacement behaviors we see are, I saw one that was like, journal about your feelings, or use your coping skills. Is there a lot? And those, it depends on how it's used or taught. I saw one once that was like, the replacement behavior was take accountability for your actions. So when we talk about a functionally matched replacement behavior, we're talking about an appropriate behavior that the person can be taught to engage in that will get them the same thing that that problem behavior that we're trying to extinguish gets them. So if I punch my staff in the face for attention, you need to be teaching me a behavior that I can engage in that will get me attention appropriately. And by giving me something that is easier, that gets me the same thing, hopefully then we will reduce the punching of staff in the face, right? But if the replacement behavior you give me is Sarah takes accountability for her actions, so if I can take accountability for my actions, or I can punch my staff in the face and get attention, which one am I going to do? Probably the one that gets me what I want, which is attention. And you're going to have a really hard time extinguishing a behavior that is getting them what they want or need by giving them a replacement behavior that doesn't give them what they want or need out of engaging in that problem behavior. Does that make sense?
Hey, Sarah.
Yeah.
So question about I don't remember what they're called, but the reason we do things in the FBA. Like the physical or escape, all of those.
The function.
Thank you.
Function.
I could not think of the word function for the life of me.
Yeah.
So I have been, like, being new, I've read through a bunch of the FBAs, and I've noticed that whenever they use the QABF, from Matson and Vollmer, it lists 5. It also lists non-socials. So if it only has non-social for a specific behavior, is that not meeting the standards of what we require?
I'd have to look at it. And I can ask the clinical team and get back to you guys, or like add something to the slides about it and reattach them. Because I've seen that as well in the past. But I feel like most of the things that I've seen that non-social tag attached to are just escape from like a person or an interaction rather than escape from like a place or a task. Don't quote me on that, because like I said, I'm not a behavioral professional. I just look at a lot of these. I can get some clarification and get back to you, but I want to say when I've looked at things and I've noticed that, I think a lot of that is escape adjacent. Does
Okay.
that make sense?
It does. It's just because I'm noticing, like, with it being in the QABF, like, they use it pretty much incessantly on my caseload.
Sure. And that might be something, if we make our clinical team aware of it, it might be something that warrants an update to those checklists and guidelines that we use, or clarification. Because if you're confused about it, our providers probably are too, and all of the other non-behavioral professionals in the division who touch these things as they become parts of our participants' plans.
Thank you.
Any other questions? And like I had up, FBAs also have their own checklist that you can use as a guide or a tool, especially since we know that FBs are coming from behavioral professionals, and as non-behavioral professionals, it can be intimidating to push back on them, but it is so important that we have an FBA that meets our expectations, because if an FBA doesn't have what it needs to have and perform the function it needs to perform, everything that comes from it isn't going to be moving us to where we want to go with those behavior supports. Okay, and then, so behavior supports continued. So we have the FBA, we got it from a qualified professional. It has all of the things in it it is supposed to have. So then we're going to use that to develop a behavior support plan. That behavior support plan must be based on an FBA that meets the division's requirements in order to meet the division's requirements for the BSP that comes from it. So if there's a behavior support plan in place, but there's never been an FBA, those are not formal behavior supports that meet our division's requirements. For behavior supports for general behavioral needs, and certainly not when there is a rights restriction addressing a behavioral risk being used. The BSP can be written by a non-professional. So you may see cases where the same professional or a different person than who did the FBA, but also a behavioral professional, writes that BSP. But in a lot of cases, what you're going to see is a non-behavioral professional will take the recommendations of the FBA and write a BSP from it. When a behavioral professional writes the BSP, good to go. If the BSP is written by a non-professional, it has to be reviewed and approved by a behavioral professional, prior to implementation. And the reason for that is that all of the things that go in the BSP as far as how to respond when target behaviors occur, how to teach those replacement behaviors, all of those things. There's a lot of situations in which our natural inclination of how it makes sense to react to a person engaging in a maladaptive behavior is actually not helpful, and sometimes even harmful as far as reinforcing that problem or unsafe behavior, which is the opposite of what we want to do, right? Because if somebody is engaging in a problem behavior for attention, and I go to them and say, let's talk and process through this, I am giving them attention. I'm well-intended, I'm trying to help, but I'm giving them attention. And so they know if they want attention, I can engage in that unsafe problem behavior again. And Sarah's going to come and talk to me and process through it in my room for an hour. And I'm going to get some one-to-one time with somebody. And so that is why it is so important that the BSP that is giving staff instructions on how to respond to problem behaviors is at least reviewed by a behavioral professional to make sure the strategies and intervention and teaching within it are consistent with the behavioral assessment and not going to contribute to the issues that we're trying to help. The BSP has some required components that it has to have, like all these other things. I have a few of them here on the slide, but again, checklist is linked that gives a full rundown of the expectations around the components of what needs to be in a BSP. The ones I want to talk about, though, are descriptions of those problem behaviors, triggers, and warning signs. So just like it's important to have descriptions of those in the FBA so that we know what we're looking at and what those functions that have been determined by that behavioral professional are associated with, we need to give those descriptions to staff then so that they know what is a problem behavior and what isn't, because there's a difference a lot of times between a maladaptive behavior, a problem behavior, a target behavior, and an unwanted or annoying behavior, because not all unwanted behavior or behavior that some might perceive as annoying is a problem behavior or an unsafe behavior, right? And so we don't want people, DSP to DSP, deciding what verbal aggression means themselves, deciding what physical aggression means, deciding what property destruction means. That needs to be laid out to them so that when they're scoring on the BSP, how many target behaviors happen in a given day, we know that what they're scoring and counting is actually problem behaviors and not things that everybody else has kind of separately decided fall under the umbrella of a target behavior. And the same with triggers and warning signs, giving an operational definition of what those things look like so staff can be on the lookout for them and be cognizant of them so that they can try to de-escalate before it gets to the point of a problem behavior or behavioral crisis, an unsafe situation as best they can. There needs to be a description of how to respond to the problem behaviors. So like the example I gave, if the function of a problem behavior is attention, we're not going to respond in a way that gives attention to the greatest extent possible. Now, sometimes it's impossible to not, just because we can't, if somebody is, smashing their head against the concrete floor in order to gain attention, there's ways that we can intervene to minimize the amount of attention that we're giving, but we still have to intervene to some extent. So it's not always possible to, not respond in ways that give the person what they're asking for to some extent, but we should be telling staff, this is what we want you to do to minimize any potential reinforcement of that to try to reduce that behavior over time. The BSP is going to be teaching that functionally matched replacement behavior. And I don't just mean like sometimes we'll see BSPs that don't have any teaching to them. It's just basically they're tracking, yes, no, did the person use their coping skills? Yes, no, did the person go journal instead of punching their staff in the face? BSPs are at their core habilitation programs. They need to teach that functionally matched replacement behavior. And then descriptions of other interventions like environmental modifications and day-to-day interactions with staff that can reduce the likelihood of those problem behaviors. Any of those things that are identified also should be in the BSP. Gail said some typical maladaptive behaviors with a BSP examples that would be appropriate would be helpful, including behavior replacement behaviors that are functionally matched. I can ask our clinical team if that's something. It's really hard because behaviors have different functions for different people. And sometimes a behavior can have a couple different functions for a single person. And so it's not like we can say, okay, physical aggression is always, with the function of, always has the function of escape. Like we can't say that because that's not the same for every person. And so saying then what a functionally matched behavior to teach would be difficult. But I can ask if they have some examples that they could share. Because I know everybody learns differently, and that's why we try to include a lot of examples where we can, because sometimes seeing examples can help us put these concepts in context of the work we do every day and understand them better. So I can try. Scott asked, what advice do you have for helping providers better coaching DSPs to better understand the teaching strategies of the BSPs? I mean, providers, we have regulations that say how, things that they have to train their staff on, but how they go about that at least at this point in time, we don't have a lot of policy around other than emergency safety intervention. So, I mean, that's difficult. What we can do is give providers feedback when we encounter situations where it seems like their staff really don't understand the behavior supports that are in place or don't seem to be following them. Those are things that should come up, for example, when there is a GER. And it is clear by how the staff say that they intervened in a behavioral crisis that they are not familiar with any of this or with that individual's BSP because they intervened in a way that is not in the BSP and is actually unhelpful and maybe even harmful, because we do see that not infrequently. Like, I see somewhat regularly, I will read a GER and I'm just like, oh, this did not have to happen. Every choice that the DSPs made in how to respond to this participant along the course of what happened here was the wrong choice, and a choice that really predictably led to escalation. I've given the example before where I read a GER where it went from a participant coming home and asking for juice to a police contact, and it didn't have to. The participant came home and asked for juice. They said, you drank all your juice yesterday. So she said, cool, I would like to go to the store and get some juice. And this is the participant that had one-to-one, so staffing wasn't an issue. She said, I want to go to the store and get some juice. And they said, no, because you had a behavioral episode yesterday. There were no restrictions saying that she needed to spend a certain amount of time at baseline before she could access the community following a behavioral episode. So this was punishment. So that's prohibited just right off the bat. That was a problematic response to the participant's request to go get juice. And then the participant predictably became upset at that response and started yelling. And they said, go to your room. I don't know many adults engaged in an argument with somebody who would respond favorably to being told by that other person to go to their room. I am not one of those people. And I would suspect that most of you aren't either. So the participant became more angry and actually responded in a way that I thought showed a lot of, a decent amount of self-regulation. She tried to leave the situation and go out to the backyard. And staff stepped in her way and blocked her from leaving because it was a power struggle then and they wanted her to obey them and go to her room. And she punched them. None of that had to happen and should not have happened, right? So we read incidents like that and we're like, have you ever seen a BSP? Have you ever read a BSP? Have you read this person's BSP? Because it doesn't appear that you did, because otherwise you would have never responded to that situation in that manner, and this never would have happened. And so when we see things like that, those are discussions then when you as SCs and supervisors are looking at that GER resolution that the provider completes after a reportable incident, they better be identifying that that person's plan wasn't followed, and they better be putting action plans in place to train their staff to respond better, to reduce the likelihood of preventable, unsafe incidents in the future. And so those are places where we can have impact, where we see that staff obviously aren't being given the oversight, the education, whatever it is that they need to follow a person's plans and to respond in ways that are helpful and not harmful in those situations.
Sarah, can I piggyback off that?
Yeah.
In addition to the provider resolution, when we're doing, if we see that a safety plan is not followed, then as part of our service review process, we can also mark that as action needed. That like we identify that the safety, that's part of our review that we have to do, looking at safety plans to make sure they were followed, and we would be requesting some sort of action even prior to the provider doing their resolution saying like, what are you doing to retrain your staff? Like this could have been avoided. And so that requires a little bit more formal of a response, because unfortunately we see cookie cutter GR resolutions where this gives you a little bit more teeth in terms of they have to respond to you. They have to tell you their plan to address our concerns and the fact that the safety plan wasn't, and how they're going to retrain staff. And so that creates that kind of that paper trail and documentation that if we see those trending issues, we have additional options.
Absolutely.
So would it be,
oh, sorry.
I'm sorry.
Go ahead.
So would it be all bad to say print off the safety plan, take it into a residential or day site and go, okay, I mean, don't show it to them, but just so you're familiar with it and go, all right, so what's in their BSP?
Yeah, I mean, those are things that as you're doing service reviews, I don't know that that's necessarily something you routinely do, but like if you have concerns, those are things that in our regulations, all staff should be trained on for sure.
It actually is something that we talk about. It's okay to ask the staff assigned to the person, what safety risk does this person have? And if they say, oh, I don't know, and they have a one or a laundry list, that is an area of concern as well. It means staff have been assigned to work with people that they have no idea. It's not their fault. They literally have no idea how they are supposed to respond. So we strongly encourage folks to go out and ask some of those questions when they do those service reviews, or if they're out and about and they see something that they makes them question, whether it's a service review or just a visit or coming in through a big workspace for folks to a team meeting, they can ask those.
Absolutely.
But if I can interject something, I'm blabby today. What I've noticed is if I'm talking to someone that's working with someone, I'll say, are you familiar with their programs? And then, I kind of see what happens. But what I've seen is that because of staffing issues, people have put people with people, they haven't been cross-trained and they haven't read anything or been, somebody hasn't gone over those things. They just kind of get thrown in. And so I bring that to their attention, and that person can have an opportunity to back up and find out more information of who they're working with and what the expectations are. But I've seen that more than once because of staffing issues for the providers, which is very sad. But it happens. It's the world we live in too. But they can fix it. They can stop for a minute.
Yeah. And that's something that is so, like, I get why it happens. There's a staffing crisis. It's nationwide. It isn't just here. But that doesn't relieve us from our responsibilities of keeping our participants safe. And we see, I've sat in and subbed as the chair on the mortality review committee and some critical incident review committee. I get cases that cross my desk through various parts of my job where a participant has died from something that was absolutely preventable because the staff weren't trained or didn't have the information readily accessible to them on exactly what we need them to do in an emergency. And that is so important. And so, we're talking about literally people's lives are in their hands. I understand staffing crises. I understand it's hard, but this is, of all of the pieces of the work that they do, this is one that cannot be compromised. And so, yeah, asking those questions, keeping your eyes open for those things is absolutely within the scope of what you're there for.
Yeah, I appreciate the feedback. I can't imagine what you've seen, but you're right. I think those questions are, and you can tell sometimes that somebody doesn't really know this person very well, just kind of feel it sometimes. So, but
and we can't prevent them. Like, we can't always have a staff that's worked with a person for years. That's not a reasonable expectation, but they can, at least that's why we have safety plans, so that there is a document they can go to say, I don't know this person that well, but these are their risks, and this is what I do if any, and this is what they look like when an emergency for one of these happens, and this is what I'm supposed to do. Okay, sorry, great discussion, but I'm going to go over time if we don't move on to the next piece. So habilitation programs. We've talked about formal behavior supports. Those are required when a restriction is addressing a behavioral risk. And I think a lot of people in their conception of restrictions, they only think about them in terms of how they address a behavioral risk, but we use restrictions for all kinds of safety risks. And we use restrictions oftentimes are used to mitigate a risk related to a participant's limited knowledge or adaptive skills. So think about a person has a restriction that they can only have a pureed diet because they don't understand or aren't able to engage in safe mealtime behaviors of fully chewing their food, not talking when they have food in their mouth, you know, all of those things that are on the PNM risk screen that are indicative of potential choking risk, right? And so they have a restriction of, you know, mealtime texture or using a smaller spoon so they can't take as big bites, things like that. Those types of restrictions would be addressing the participants' lack of understanding or skills in eating safely. And so when we use a restriction for that purpose, we have to have a formal habilitation program to teach the skills or knowledge that the person would need to exercise that right that we're limiting safely. So if a person has a restriction that they can only use a youth-sized or small bowled spoon to eat their meals because otherwise they'll take too big of bites and they will choke and bad news bears. We're going to then have habilitation in place to teach them setting down your spoon in between bites, taking a sip of water between bites, chewing thoroughly, not talking when we have food in our mouths, those types of things. And when the participant learns from those programs and is able to engage in those safe mealtime behaviors, that would be when that would support reduction of that restriction over time. The expectations for HAB programs that address restrictions like this are the same as our division's general requirements around habilitation programs, which is that they are smart, all of those different things. And they really need to be teaching specific skills and knowledge that will help the participant exercise their rights safely in the future. Sometimes we'll see where there's, a restriction on a participant's contacts with their family because their family are not great people and, you know, it's damaging to the participant's mental health. And then subsequently there's another safety if they have interactions with their family. A lot of people will base reduction plans around those restrictions around, well, when the family's safer, we'll reduce the restriction. No, we can't control other people. We can't do anything about that. The risk there is the participant doesn't have a good understanding of relationship boundaries and how to draw them for themselves, how to maintain them for themselves, how to choose what types of relationships they want to have in their life. And so we're going to have teaching in place to support them to gain those skills that they need to then manage those family relationships so that they don't have that maybe damaging impact on their mental health and subsequently their, you know, unsafe behaviors. So sometimes we'll see a restriction like that and the habilitation to go along with it is just like a generic communication program that has nothing to do with teaching social boundaries, relationship boundaries, any of that. It needs to be something that by learning that specific skill, it is going to contribute to the potential reduction of that restriction in the future. And I also want to note that there are times, even when a risk is medical or related to a person's physical abilities or disabilities, that habilitation can still be appropriate. Because sometimes, you know, we can't change that a person is aging and their mobility is just slowing down, right? And then that's contributing to fall risk. Like we can't habilitate out of aging and the mobility issues that often come from that. But if we have a restriction in place that they have a safety belt in any chair that they're in, because they'll try to get up and walk when staff aren't there to help them and then fall, We maybe can't habilitate the mobility issue that contributes to that risk. What we could habilitate, though, is waiting to get up until you've called for staff to help you and they're there to help you. That could potentially be taught with some folks. And so sometimes there is a skill that maybe doesn't seem to be directly related to the risk, but there's a thing that we could teach them that would reduce that risk enough to potentially make that restriction unnecessary. And so we always want to be looking for those opportunities too. And then the last bit is other supports. So sometimes there are things that there is no habilitation that we could put in place, no behavior supports, no nothing that would reduce that risk over time. Seizure disorders are one of them. You can't teach them to wait to have a seizure until staff are there to keep them safe. You can't teach them to have less seizures or to have no seizures or not have a seizure in the shower. It's not a thing, right? And so, but we still need to be documenting what things are happening that reduce that risk. And so outside of the restriction. And so that could be a number of different things. It could be therapies. So if somebody has a fall risk and they have a restriction related to it, but they're engaged in physical therapy to improve their mobility and reduce that fall risk, you want to take credit for that. That's fantastic. And that is potentially going to reduce the need for that restriction in the future. The same with medications that they're taking, seeing their physicians. So if it's a seizure disorder, I take my anti-epileptic medications and I see my neurologist as scheduled. That helps mitigate that risk presented by that seizure disorder. It can also be educational programs like circles. Some people like circles, some people don't, but like there's different like, you know, educational programs out there around relationships. You know, you could, somebody could be engaged in education with a dietitian if they were newly diagnosed with diabetes to help them learn how to manage that safely with their diet. That's education that contributes to reduction of risk over time. Exercise programs are another thing. So this could be a lot of different things, but it's anything that we're doing or the participant is doing that contribute to reduction of that risk over time. So now the why. Why are these things so important? And some of this is obvious, but I really want to emphasize it. Safety plans are needed and required whenever a participant has identified risks that need to be communicated to the DSP supporting them, so the DSPs know exactly what those risks look like and exactly how they need to respond, because there are times when responding in exactly the right way really quickly can be the difference between life and death, between a really good outcome and a really bad outcome for our participants and for others. And by and large, unless you're a person who's been in a lot of emergencies in your life, human beings are bad at responding in emergencies. We tend to freeze. And so preparing staff to know what an emergency might look like for a participant and exactly what you want them to do before that thing happens substantially increases the likelihood that they're going to respond in a way that's going to lead to a better outcome and that they're going to do it quickly. They're going to call 911 when the person is choking instead of calling their home manager and then calling the on-call nurse and nobody answers and blah, blah, blah. And then eventually they reach something and they say, take him to the ER, and they take them there by car and the person dies in the car on the way instead of just calling 911 from the jump. We need to set our DSPs up to be successful when bad things happen. And that is at its core what safety plans are for. And so sometimes you'll have providers push back and say, where does it say I have to have a safety plan about this? I would challenge them and say, why wouldn't you? Why, even if this risk is relatively minor, even if this occurrence is relatively rare, why wouldn't you want to do your level best to set your staff up to intervene exactly how we need them to to keep everyone involved safe. What's the downside? Regardless of what our policies are, regardless of what we require, why wouldn't we? And the other piece here that I have on the side is it is in a lot of cases so important that there is a consistent response, especially with behavioral needs. It is important that the response is consistent across every person that participant engages in that behavior in front of. Because if a participant knows, okay, I punched this stuff, I didn't get attention, I punched this stuff, I didn't get attention, I punched this stuff, I didn't get attention, I punched this stuff, and I got the attention that I wanted, that is an intermittent reinforcement schedule, which makes behavior more likely to occur. That inconsistency then makes everyone else's jobs harder who are following that safety plan. Consistency is so important. And as I've said previously, when a restriction is implemented, that is just one of the many situations in which we have to have a safety plan because if a safety risk is so significant that it justifies a limitation of somebody's rights, we have to have a safety plan for it. Behavior supports, and why are they important? I've touched on some of this, but it is so important that these supports are developed by professionals and that they have all the required components, because when we don't know the functions of the behavior, as I've mentioned, sometimes what seems like the best and most logical response might actually be making things worse and not better. And if we aren't teaching those functionally matched replacement behaviors, we aren't giving the participant a way to meet their needs, their human need for attention and interaction, their human need to escape painful or uncomfortable or anxiety-inducing situations or people, a way to appropriately get the things that they want, food, drink, money, you know, all those different things, entertainment. If we aren't giving them appropriate ways to get those things, we don't have a shot at extinguishing those maladaptive, unsafe behaviors that get them those things. No matter how many coping skills we teach them, no matter how much journaling we teach them, no matter how much we try to teach them to take accountability and to feel bad after they punch themselves in the face, if we aren't giving them a safe, appropriate way to get attention, they're going to go to what they know. Somewhere along the line, they learned that if I engage in this thing, in this behavior, I will get this thing from it. And until we get them a different way to get what they want and need, they will continue to go down the path of that unsafe behavior because that's what they've learned and that is what has worked throughout their lives. And with habilitation, as I say with all of these things, if we're going to go to the extent of limiting somebody's human rights, it is our obligation and responsibility to make active efforts to the greatest extent possible to give them whatever they need to exercise the right that we are limiting fully and safely. And that may not be a realistic goal for some people. I will never say never, but you know, it's possible that it may never work. It doesn't matter. It is our responsibility and our obligation to do our level best to try to help them have the things that they need to have to exercise their rights fully and safely. That is what any of us would want for ourselves, and that is what our participants deserve. And we don't learn by magic. We don't just spontaneously learn things, right? And we also don't learn by having other people make choices for us or to keep things away from us that we make bad choices about, right? And so we have to do the teaching. And I've heard before, well, there's so many programs. There aren't that. I mean, I come from an ICF background. For those of you who don't know that about me, I did my case management years in my background at BSDC, which is an institution where we have programs coming out of our ears for each participant. So I've heard at times people say, well, we're prioritizing other things for rehabilitation, so we're going to do this informally. What could possibly be a higher priority to teach our participants than a skill that will mitigate a risk that requires the limitation of their fundamental rights as a human being? And what better outcome and work towards independence could we achieve than getting to a point where a person who has had rights restrictions can exercise their rights fully and safely? We are always going to prioritize rehabilitation around things that require limitations of a person's rights. Considerations. So these are just some, I guess, food for thought, and some of them we may have already touched on. We want safety plans to be as specific as possible and to avoid using ambiguous language. I touched on this a bit, but a term like verbal aggression can mean a lot of things to a lot of different people. Sharps can mean a lot of things to a lot of different people. How many times do you see a BS or a safety plan? It's just sharps restriction. What does that mean? Probably knives and scissors. What about safety scissors? What about razors? What about safety razors? Box cutters, forks, knitting needles, butter knives, letter openers. All of those things are sharp to some extent. It could be used to stab somebody, maybe not slash somebody. What needs to be limited for sharps really depends on the person. It could be all of those things, or it could be just a small amount of those things. Pencils. Thank you, Cindy. Pens and pencils. There's so many things out there. Another one we see for folks with pica, they're not supposed to have small objects around them. What's a small object? The size of my palm, the size of the end of my thumb, the size of a dime, something that fits through a toilet paper roll. What does that mean? Because if you say limit the person's access to small items, every DSP who reads that is going to have a different picture of what that means pop into their head. Sometimes I'll see the term contraband and I'm like, I know I stopped working in prison like 15 years ago, maybe not that long, 10 years ago. What the heck does contraband mean in terms of one of our participants? You have to define those things in your documentation of restrictions, and provider have to communicate those descriptions to their staff so that it is implemented the same every time, because we don't want them being overly restrictive and restricting the participant in ways that aren't absolutely needed to keep everyone safe. But we also don't want them reading that really ambiguous term and under restricting, because then we are not mitigating the safety risks that is the reason that that restriction is in place. Yes, you're right, Scott. So many things can be weapons. I used to work in prison, and with enough time and boredom and malicious intent, just about anything could be a weapon. So you have to look at the participant's history and their patterns of behavior and define what you mean if there's something that participants' access has to be limited to. Safety plans should also be as simple and straightforward as they can be, because when there's an emergency, we want the DSPs, if they're like, oh shoot, I don't know what to do, we want them to be able to quickly and easily locate the information that they need to intervene quickly and appropriately. And so if I see the whole manual copied and pasted into the person's safety plan, that, you know, there's nothing in our policies that say that the provider can't do that. But if we're seeing that staff are struggling to intervene in accordance with the interventions agreed upon by the team in a situation, that might be a point in which to talk to the provider and say, you know, are there ways that we can simplify the safety plan so that they know if X happens, I do Y? Another thing is, like I said, it is allowable for providers to have, you know, a seizure protocol, a fall protocol, you know, It doesn't have to be all in one comprehensive safety plan, but if we're seeing staff struggle to intervene in a timely and appropriate manner, maybe suggest that, you know, could we centralize some of this so that there is a one-stop shop that your staff know that they can go to see what the person's risks are and what they need to do about them. With behavior supports, this is something that it is not uncommon for us to see providers and families that are reluctant to consider formal behavioral supports. You'll get people say, well, I don't want that stigma, or I don't, you know, and there's a lot of reasons that folks give for not wanting FBAs. At the end of the day, though, it is an assessment, like a risk screen. I mean, it has to be done by a behavioral professional, but it is an assessment like a risk screen, like the DI, like the ICAP, like when they go to the doctor, when there's something medically wrong with them and they get that assessed. If someone was having medical symptoms, we wouldn't be like, this seems minor and infrequent, so we're just going to DIY a plan here. You go to the doctor, you go to the professional that can say, this is probably the problem and this is what you should do to treat it. Why would we not do the same thing with behavioral needs? And so sometimes that reframing of helping them understand this is just an assessment so that we can get information from a person who is trained and qualified to do this that will help us better support them to be safe and to hopefully reduce the incidence of these behaviors over time. Also, we get questions about when a restriction isn't used across all providers who support a participant, or the behavior is mostly seen in one provider's services or in one type of setting. The provider might not want to implement a BSP, like, oh, they only have a problem with day services, so we're not going to do a BSP. You know, that may be the appropriate solution in some situations, but I would caution you to discuss those things carefully. If the team genuinely feels that the risk doesn't exist in that setting, then it may be appropriate. But if there is any reasonable likelihood that even on rare occasions, we may see that unsafe or problem behavior in the setting that it typically doesn't occur in, we need to be documenting those incidences of target behavior. We need to be teaching those replacement behaviors, and we need to be intervening appropriately and safely and consistent across environments. So those are things to discuss. And the last thing I'll say about that is sometimes providers will come to a meeting and tell you all, and you will put in the plan, this doesn't happen at day services, but then the plan gets pulled for my team's review and we're, you know, skimming T logs and we're like, oh, it happened there and here too, and there. So I would also encourage you, when you're told, oh, this doesn't happen in this setting, I would be looking at any documentation they keep of what the staff who are with the participant day in and day out say is happening. Because sometimes the coordinator who attends meetings truly doesn't know what's happening on a day-to-day basis. So. And then with habilitation, I touched on some of this already, but really think about what knowledge and skills a person would allow that person to exercise that right that's being limited safely. And sometimes there's a skill that can be taught that would meaningfully reduce the need for the restriction isn't directly related to the issue causing the risk. Like the example I gave of the risk is there's a fall risk. We aren't going to habilitate out the fall risk probably. But if we can teach the person to ask for staff help and to wait for staff help before trying to stand up and walk, then we've reduced the risk that requires the restriction. And I touched on, I think I touched on most of this, but please, please, please do not just view habilitation related to restrictions a person has as a box to check off. So we'll just say, oh, their communication apparently covers this, or oh, they have a daily routine program. If those things aren't teaching specific skills that will contribute to them gaining the skills they need to reduce that restriction over time. Again, it is our obligation to make every effort that we can to teach the person the skills they need to exercise all of their rights fully and safely. It's not something to compromise on or to cut corners on. That's not what any of us would want for ourselves if our rights were being limited. But also, sometimes it isn't a single skill or piece of knowledge that a person needs in order to eventually exercise that right that's being limited safely. And so a program can break that down and just tackle one aspect of it at a time. And as long as you're clear in documenting, you know, this is a part of supporting the person to build skills XYZ to reduce this restriction in the future, that's absolutely what we're looking for. We just want to make sure that we're making those connections. So that is all I have. I don't have the full 30 minutes that we usually try to have for questions and discussion, but we did talk through some of the questions as we went. I think, Alyssa, I don't think I answered your question as we went. I gave an example of somebody who has to be at baseline for a number of minutes before they can, you know, access the community again. Is that considered restricted? Yes. So saying that we're not going to put you in a car and take you out to a public place when you are actively behaving unsafely, that's not a restriction. That's common sense. If I'm having a behavioral episode and punching holes in walls, I don't have a right to demand that someone who's with me put me in their car and take me someplace. That isn't a reasonable ask. And I don't have a right to ask or demand that of somebody. But once I am back at baseline, I have a right to begin to access the community again. And so if we have something in place that says they need to be at baseline for 30 minutes before leaving a safe area after a behavioral crisis, if they need to be at baseline for 6 hours or 24 hours or whatever before accessing the community, those are all rights restrictions, and they need to be backed up by evidence that the person, even when they appear to be back at baseline, continue to be unsafe.
And it has to truly be that imminent threat to others. It can't just be that there's like, there has to be, you have to meet all the other requirements of the restriction, because you got to be really careful that you don't run into that subjective on the staff's what they think is baseline or what's allowed and what's not for them to be able to go back into the community, because then you're tiptoeing into punishment, which is prohibited.
Mm-hmm. Yeah, and that type of restriction is definitely something to be careful for with punishment. I had a participant who had a restriction like that. It was 24 hours. And it was because we had years of behavioral data that told us that when he had a behavioral crisis, especially if it was so bad that it required use of emergency safety intervention, that even when he appeared to be back at baseline, he was very, very likely to re-escalate in the hours afterwards. And so that's why there was a restriction in place that said he had to be a baseline for 24 hours, because that is when we well and truly knew that he was back at baseline, not just appearing to be back at baseline, but still internally, psychologically, physiologically escalated in a way that was very likely to lead to subsequent very unsafe situations. So if there's that type of evidence in the behavioral data, a restriction like that might be appropriate, but it shouldn't just be based on well, we need 3 hours before we feel like they're safe. That's not how that should go. Any other questions or anything, Stacy, that we touched on last time that didn't get asked about this time that we could talk about?
I think maybe, I don't know if we spoke to like BSPs, like revisions. We talked about clinician approval, but something that came up last time is that providers can make some revisions to the BSP if it doesn't change the intent and what was recommended by the clinician. So sometimes it's criteria changes or adding additional objectives within the recommendations that were already suggested, and those don't necessarily require approval. I think the other thing we talked about, as I asked you to speak to, there's a lot of confusion about how BSPs and ISP programs align. Like a BSP is an ISP program. There has to be that meaningful data collection and that teaching. And I think sometimes that we lose sight that we then have to look at them like we do other ISP programs. They have to be smart. They have to be achievable. If they're not making progress in a year, we have to talk about revisions. So maybe if you could speak to that a little bit.
Yeah, absolutely. So the second part of that, yes, BSPs, and if you look at the checklist, at their core, they are a habilitation program teaching those functional replacement behaviors. But in order to assess the success of a BSP, we need to measure just more than just the learning of the replacement behavior. We also need to measure the incidences of those behaviors that we're trying to reduce, because we may think that we have a great functionally matched replacement behavior and we teach it and the person learns it and they've got it, and we're not seeing any meaningful reduction of their problem behaviors or their unsafe behaviors. Then it's not a good replacement behavior. And we need to go back to the drawing board, because the point of that replacement behavior is to give them a way to get what they get from the problem behavior without engaging in the problem behavior. And so no matter how elegant it is or how functionally matched it is, if it doesn't perform that function of reducing the problem behaviors, it isn't working for what it's intended for. So that's why there has to be meaningful data collection. And I touched on, there needs to be teaching. It needs to be more than just tracking, did this person spontaneously use their coping skills, yes or no? That's not teaching, that's just observing and measuring. You're observing and measuring their performance of those coping skills, just like you're observing the performance of those problem behaviors and documenting how many times it happens or whether or not they happen. That's not teaching. So there need to truly be teaching methods in actually teaching a replacement behavior. And sorry, Stacy, what was and yeah, like you said, Stacy, if the goals need to be SMART, if they're not achievable, they need to be revisited. All of that stuff that we have around habilitation programs needs to be present with a BSP. It's just that a BSP has some extra things, though descriptions of the target behaviors, the triggers, the antecedents, the environmental modifications, like it has those extra things, but it has to conform to what we expect for a habilitation program too.
And if they pass it and then the provider says, well, we just do a safety plan, and we don't have behavior data that supports that it actually was passed, then we probably need to ask the clinician to relook at the teaching, because clearly whatever was suggested maybe just did not work. And so it can't just be, well, boom, they passed, we go to a safety plan, especially if behavioral data shows that all those same behaviors are still present.
Exactly. A person doesn't pass their BSP until they don't have maladaptive problem target behaviors. If they have successfully learned whatever we're teaching in the BSP and there are still problem behaviors, our work is not done. That is the time to then get a new FBA or go back to the drawing board with a behavioral professional.
I think the only other thing I put in the chat, because just in case people aren't following that, because it can be distracting, just a reminder, these PowerPoints cannot be shared externally. They are internal documents. We have our rights and restrictions SOP has a lot of this information in it, and it's the one document that's been vetted by legal and gone through all the DHHS hoops to be shared with providers. That's kind of a refresher for people who've been here, but also maybe something new SEs just are not aware of that we cannot share. If it's on our public website, fair game. Anything else that's created internally, except for the rights and restriction, cannot be shared externally. So, but it all came from resources that can, so we can point you in the directions of the resources that can be shared.
And that's why I link these checklists, because I think these are a fantastic tool that really break down, if these components aren't present, I don't care what credentials you have. I can't accept this assessment from you. And Amy, or not Amy, dang it. Names are giving me trouble this week. Stacy, what was the first thing that you asked?
Oh, on BSPs?
Yeah.
On that piece, that they can be edited as long as it's not changing any edit. That clinicians don't have to approve every change as long as it's not changing what their recommendation is. So sometimes it's criteria, sometimes they add additional objectives. As long as they're not changing what they recommended, you don't have to have that clinician approval on every single edit.
Yeah, if you're just changing the, you know, numbers and percents in the goals or adding new ones or whatever, that doesn't require approval. But if something is being changed about the substance or the intent, if they're changing definitions of behaviors, if they're changing instructions about how to respond, if they're changing things about what we're teaching with that BSP, that has to go through a behavioral professional. And if it is outside of the behavioral assessment that BSP is based on, like if the person is displaying a new behavior and they want to add it, no, we got to get a new FBA at that point. And folks often ask, like, how often do we have to get a new FBA? There is no time frame, but you always have to, if somebody has behavioral risks, you always have to have an FBA and supports based on that FBA that is consistent with the person's current needs and that is meeting those needs. If at any time there's any question about whether it still meets their needs, that is the time that we should be asking for new assessments. The only caveat I'll give, because somebody asked this last time, was what about if the FBA is working and this person had this behavior and now they don't anymore? So they still have the other behaviors in the FBA, but they don't have, you know, one of them. Say we were able to successfully teach them to stop engaging in verbal aggression. And we're really not seeing that anymore. You don't need a new FBA at that point. Because the remaining behaviors, if they're still adequately being addressed by that FBA, you would just document that at the time of the FBA, I had these behaviors, I made progress, and I don't exhibit this behavior anymore. So we're in a bit over time, but I hope everybody found this helpful. If you're marinating on this as you go back to your work and you have any questions that you didn't think about while we were going through this, please feel free to reach out. I'm always happy to help or to discuss further questions you have or specific situations that you have that you're not sure how what we've discussed today applies to it. Always reach out to me and my team. We're here to support you guys. So, and with that all said, really appreciate you all taking time out of your day to join us and have a lovely afternoon.